Okay, it's just afternoon, so good afternoon, everyone. Thank you for coming out to this community meeting on Ebola. I'm Dr. Bill Paul. I'm director of the Metro Health Department. It is my pleasure and my honor to lead your local public health department, which gets to have this wonderful new building. For those of you who are really interested in the new building, we are having an open house tomorrow from 3 to 6 if you'd like to look to see a little bit more of it. But the agenda today is really about Ebola. Obviously, this has been a big topic in the news, and there's a lot of concerns in the community. And we, in public health, we play a role. You know, what brings us to work every day is protecting and improving and sustaining health and well-being for everybody in Nashville. And we think that when a new threat comes up, it's really important that people have good information, that people have places that they can go to get more information, get their questions answered, but also that as a community, we have a response to protecting and sustaining our health. First thing to know is we're not having this meeting because there's something special going on in Nashville. There have not been any cases of Ebola reported in Nashville, nor in the state of Tennessee, and so there's no particulars of cases here to talk about, but there is a general situation, and it's on the news all over the country. And you're hearing about Dallas, and you're hearing about West Africa, and people are a little bit on edge. So we want to make sure that we get some facts out. So once again, thanks for being here. I know it's lunch hour. If you brought your lunch, you can go ahead and eat. But here's the basic questions for the next few minutes. We'll have plenty of time for questions at the end. But first, what is Ebola? How does it spread? Where is Ebola spreading? Who is at risk? And then how will we, as a community, contain Ebola? So first of all, what is Ebola? Well, it's a virus. It's a disease caused by a virus. There's a whole lot of stuff in the media in addition to the disease caused by the virus, but the enemy is really a virus. The enemy is not a group of people or a place on the globe or a government or anything like that. It's really a virus, and part of what we deal with in our lives here in this country are viruses, and so that's what the enemy is. This particular virus is not brand new. It may be new to us in this country, but it is not brand new. It was discovered in 1976. It has come up from time to time on the continent of Africa since then. 23 different outbreaks in Africa from 1976 to 2012. Each one of those outbreaks was a very significant public health event. People died. People were very sick. But each one of those was contained. We're in a different type of a situation in West Africa now, where we have some places where the outbreak has not been contained. And so that is probably one of the biggest concerns we have is about the ongoing outbreaks in West Africa. But what is it? It's a virus. We need to treat it with respect, and we need to take it seriously. Obviously, in this country, we feel like we've got a lot of things in place. We feel like we're confident that we can contain this virus and that we can not let it have a huge, significant impact on our health and well-being. But we need to treat it with respect. Ebola does cause a severe illness. In the West African outbreaks, around 70% of the people who are getting sick with Ebola are dying from it. There are not specific approved drugs. Now, there are very few viruses where there are really good drugs, so that's not particularly unusual, but there are no specific approved drugs for Ebola, and there is no vaccine. And this final one, even though more of us will die from influenza, more of us will die from auto accidents or gun violence or from smoking, even though all of those are threats that are with us every day, this is something new. It's something unfamiliar. And so it's completely human nature for us to want to understand it and to want to be protected from it, and because the unfamiliarity of the threat makes it especially concerning for us. And so part of the point of having meetings like this is to make it a little more familiar, not to get friendly with it, because we have to respect that it can be a very serious situation, but to make sure that we have the facts, make sure we're talking about really what the disease is and how it's transmitted. What are the symptoms of Ebola? Early on, it's very much like the flu. Fever, usually a high fever, over 101.5, severe headache, muscle pain, weakness, often a sore throat. Later on, diarrhea, vomiting, abdominal pain. A lot of the patients who are dying are really losing so much fluid that they're not surviving. But those are the symptoms, and in some cases, there's bleeding and there's bruising that makes the disease even worse. How does Ebola spread? It's really important to know this because when it's a new threat, we're concerned. We're concerned about how it might affect me, and how it might affect my family, how it might affect me in my work, whether I'm dealing with the public or in a healthcare setting. First of all, Ebola is really only spread from somebody who is sick. You can't catch Ebola from a person who doesn't have any symptoms. Even if they were exposed to Ebola, when people have tried to find the virus in somebody who was exposed to Ebola, oftentimes, even when they're early in their illness, they're not contagious. But somebody who's not sick is not contagious. We have to remember that. Early in illness, you do need to have some concern about whether a person's infectious. And then later in illness, when people have, again, diarrhea, vomiting, bleeding, those can be very infectious situations. And after death, it's unlike some of the other things that we might deal with, the body can be very infectious. And you see a lot of transmission in West African countries because of the difficulty of changing traditional ways of saying goodbye to people who've died. So, from a symptomatic person, not from a well person, but from a symptomatic person, how do we actually get Ebola virus? It's direct contact. So it's direct touching contact with blood or body fluids from a person who's sick or who has died from Ebola. And so it's blood, it's vomit, it's urine, it's feces, it's sweat, semen, saliva, and other body fluids. And so most of us, most of the time in our work or in our day-to-day lives, are not having direct touching contact with the body fluids of other people. You have to sort of stretch your imagination to come into those kind of situations. But you need to know that that's how Ebola is transmitted. Somebody's sick, and then somebody has direct contact. And it's not, typically it's not, or it is not direct contact with intact skin. It's through a break in the skin. It can be if someone gets the virus on their hand and then rubs their eye or rubs their nose. So with a mucous membrane, you can see the virus transmitted that way. But again, somebody's sick or they've died, and it's direct contact with body fluids. What else? Objects contaminated with the virus, especially things like needles and medical equipment. So in countries that are resource poor, I'm sure that there are healthcare settings where they are low on needles. They don't get enough needles, and and in some instances they might, in order to save lives, reuse needles. We don't do that in this country, but that would be a big risk for transmission of Ebola. Medical equipment, if it's not completely cleaned, can be a source. Finally, infected animals, and this is one that's not so much a concern in this country because what we're talking about here is in African countries when people hunt and kill wild animals to eat. In the preparation of those animals, that's really how Ebola jumps from where it usually lives out there in nature into us as humans. And so you can know that, but I think that we don't have a big concern about infected animals in this country or about food in this country. The incubation period is the time from when you get exposed, that's when you touch body fluids of somebody who is ill, to when you might get sick. Usually that's 8 to 10 days, but it can be up to 21 days. So we use that 21-day limit as like an outside outside interval on when the risk might be. So if somebody's been in contact with a sick person, if they've gone 21 days and they're not sick at all, they're not going to get Ebola virus disease. Things to remember. You know, it's new. There are other viruses that spread in different ways, and we sometimes, because they're familiar, we forget. But this virus does not spread in the air. It does not spread through water. It doesn't spread through food, unless, of course, you're hunting and eating wild animals in Africa in an area where the virus is. But there's not a concern in this country about foodborne illness with Ebola virus, as we have other viruses that can do that, but not with Ebola. It's really important to talk for a little bit about where the virus is spreading, because it's not everywhere in the world. It's not everywhere in the US. It's not everywhere even in Africa. On the lower right here, you see a map of Africa, and Africa is a big place. Africa is not a country. It is an enormous continent, and from time to time there have been outbreaks of Ebola in different places. But where we now have ongoing transmission, where the virus is not under control, is really in 3 countries in West Africa: Guinea, Sierra Leone, and Liberia. You've read in the paper, you know there are cases in other places. I will talk through a little bit of that. I'm not going to talk in great detail about individual cases, but I think it's important to have some background on sort of where is the virus and where is it of concern. You see Nigeria here. I'll talk about that in just a second. So there's kind of different categories. There are 3 countries where there's widespread transmission, many villages, you know, huge impact. There's not, the epidemic is not under control. And that right now is in Liberia, Sierra Leone, and Guinea. And you can see that there have been thousands of cases and even thousands of deaths in those places. And it's a huge concern, obviously, for us, that we'll all breathe a huge sigh of relief in this country when that situation is under control. But that situation right now is a huge focus for both CDC and for a variety of partners around the world. Countries that don't have widespread transmission that you want to know about, the Democratic Republic of Congo has an unrelated outbreak. It's a different strain of Ebola, and it's kind of in a remote area. It's not the same category of concern for us. But there are 70 cases and 40 deaths in the Democratic Republic of Congo. Senegal had 1 case. The case was in August. I'll talk about that in a minute. There were no deaths in Senegal. Nigeria had 20 cases with 8 deaths, and right now that's all been controlled. There's not ongoing transmission, there's not ongoing risk in Nigeria. In the United States, there have been cases cared for in different places. Obviously, we're all focused on Dallas because there was 1 case of a gentleman who came and developed Ebola in this country, and then 2 healthcare workers who were infected in caring for that gentleman. That's a very intensive investigation. You know, we'll talk a little bit about the investigation and the control of Ebola, but that's not a situation where, oh, we don't know what's going on in Dallas. You know, anybody from Dallas can be infected. It's not a widespread infection situation. What we have is people who've been identified as contacts, and that those individuals are being followed closely. And so the need to be concerned broadly about Dallas or broadly about the whole United States, I would say should be pretty low at this point. And we'll talk a little bit more about that. Spain, there's been a little bit of a similar type of situation. I'm not going to talk about Spain right now. So who could spread Ebola? If you put all the information we've talked about so far, the person who could spread Ebola is somebody who's sick, and they're sick with Ebola. If they've got Ebola, what does that mean? That means that they've had direct touching contact with somebody who themselves had Ebola, right? And that means they've touched blood or body fluids of an Ebola patient, so that's somebody with symptoms, or who has died from Ebola, within the 21 days before they got sick, right? So that you think about all the people you encounter, how many people fit that definition, even if you're taking care of sick patients. And you can actually ask some questions. If you're in a healthcare setting, you can ask some questions, and if you get good answers to your questions, your level of concern would go down. There's if a man survives Ebola, the virus can survive in their semen for up to 90 days, and so that's just something that's been observed. I don't know if there's been any cases that occurred that way, but when we say who could potentially be a source of Ebola, who could spread Ebola, that would be in a complete answer on that one. So, some of us are in healthcare settings, and people come to us. It's, we're heading into cold and flu season, and common things occur commonly. So we're going to see people with the flu, all of us, in our families or in schools or what have you. When would those symptoms make me worry, or make a person worry about Ebola? Again, you have to remember, how is it spread, and where is the virus occurring in the world right now? And so if somebody's sick, they've got a fever, they've got a headache, they've got muscle aches, if that person touched blood or body fluids of a person who was ill or died from Ebola, that's one thing that has to be in place. If a person traveled to Guinea, Sierra Leone, or Liberia within 21 days before they became ill. So if you're in a business of checking out people who are sick, it's really important to do that travel history. It's important to know whether your patient who's got a fever has been in one of these countries within the 21 days before they came sick. And it's essentially, for us right now at this moment, it's 3 countries and it's 3 weeks. It's not all of Africa. If they visited Nigeria 3 years ago, that's not it. If they were in Dallas, we just talked about Dallas. History of travel to Dallas doesn't raise the level of concern. So how will we contain Ebola? So we know that there's outbreaks going on in West Africa. It shouldn't have been a surprise that we might get a case, and we got a case in Dallas from those outbreaks. We might get a case here in Nashville. What would that mean? And what would we do? I said earlier that we have to take it seriously. This is a serious disease. But the basic steps are steps that we use for other infectious diseases. They're steps of what our healthcare system does, and they're steps of what the public health system does. They have to be done very carefully. They have to be taken very seriously. But we believe that in Nashville and in other parts of the country, we will not see sustained transmission. We won't see it spread in public places because of the basic things that we have in place. So what are the steps? First, find the patients. You identify and isolate and care for patients with Ebola virus disease. All of us have just heard who would be at risk for Ebola. If somebody has symptoms, they've got that travel history, you want to get them in the hospital and get them in isolation. You want to protect the healthcare staff so that they've got the right equipment and that patient is that the virus can't spread. Second, we want to prevent spread. I just said that. We want to prevent the spread from patients and bodies, especially to healthcare workers. And then we want to identify contacts. So anybody who might have touched body fluids of somebody who's sick, and we want to find them, and we want to make sure they're okay, that they don't have symptoms, and then follow them for that full 21 days. And really, that's called a contact tracing or contact investigation. If they don't develop symptoms in those 21 days, we're not worried that they're contagious, and they will not get Ebola. Ultimately, we do expect some cases in the U.S. as long as the epidemic in West Africa is not completely controlled. I'm repeating myself a little bit, but it's okay to do it. So finding cases, fever and symptoms, right? History of travel and contact with a case. Once you have a patient who you think might possibly have Ebola, it's important to isolate them and take care of them and protect the healthcare workers. And then a blood test is what is done for Ebola, and it's done through the state and the CDC, and that can be done very quickly. So there may be patients who come back from West Africa, they've got malaria. Malaria is still more common. It's a very common illness. So people come back with other things from those countries, and they'll have a fever, and we'll want to do all these things to check it out and protect ourselves. But then if the blood test and the follow-up blood test are negative, then we can stand down and we can make sure that we're treating the correct diagnosis in that person. Contact tracing. We really want to find everyone who's come in direct contact with a sick patient, follow and monitor the contacts for 21 days, and this is really kind of checking how they're feeling, checking whether they have a fever. It's not putting them in isolation, because remember, if they don't have symptoms, they're not contagious. But everybody's concerned. You don't want to lose that person. You want to make sure that you're able to follow that person for the full 21 days. If a contact develops symptoms, then that person needs to be isolated, tested, provide care, and trace their contacts. You don't want to miss the contacts. If they get lost and they get sick, then they can spread the virus further. And that's how the outbreak keeps going, is you have a contact that gets sick and starts spreading the virus to other people. Preventing the spread, especially in the healthcare setting. This is not a lecture about personal protective equipment. You're going to see a lot of that in the news, and the CDC's got lots of resources, and there's been a lot of concern about that. I would say that the personal protective equipment, if you're not used to doing it all the time, if it's not second nature, if it's not a habit, it is so easy to not, and I don't know, there are people, first responders in the room that use different types of personal protective equipment. It's got to be taken seriously, and what I think we've heard people moving towards for those people in healthcare settings is a buddy system where somebody's watching you do it. Even somebody who's very experienced. It's in the newspaper today. Dr. Zane from Memphis mentioned that he does this all the time. He did it for the Ebola stuff, and it was so easy to make a mistake, or so easy to leave a little bit of skin uncovered. So it's a very important issue. We're not going into the technicalities of all that today, but it is kind of a very important thing with Ebola, and Ebola spreads a little differently from other viruses that hospitals have been used to working with. Safe handling of bodies of patients who die is also something that is a special issue for Ebola. Now, we're going to do all this. What makes us confident? Why do we think that we're going to have success with this? I want to talk through just a couple of recent experiences in West Africa, which doesn't have the resources that we have, and kind of what happened with them with Ebola that was introduced. In Nigeria, I remember I mentioned 19 or 20 cases in Nigeria earlier. So there was a patient. He flew on an airplane. He was sick. He flew on an airplane from Liberia to Lagos, and that's a city of 21 million people, on July 20th. He was sick for, 5 days in Lagos and died on July 25th. What happened there was the public health folks went into emergency management mode, identified 894 people who might have been in contact, including all the people on the plane. 18,000 face-to-face visits as they tracked all those people through time, 21 days. Ultimately, there was some spread from that gentleman, but only 19 cases, and there wasn't case after case after case. And in that city of 21 million people, you didn't see this enormous outbreak and an epidemic of Ebola virus. And that would be a place where you would really worry about it, with 21 million people. Senegal, patient traveled from Guinea in August and became ill. There were 67 contacts. There were 33 healthcare workers. They were all identified and tracked, and there was no spread from that case. So there's examples of this, and there's other examples even from West Africa where this approach of really being very careful about getting the patients isolated, identifying them, getting them tracked, and making sure that if somebody gets sick, they get into isolation quickly, that you have much less impact and you don't end up with community-wide concern and community-wide spread. So we do believe that this approach will make a difference if we ever have a case here in Nashville or with any case that happens in the U.S. So we can't just say, oh, we'll be fine. We've got to prepare. And so obviously there's different things that we're doing as the local health department. We work very closely with the state health department, which has a statewide leadership role in this. We work with the hospitals. Both the state and us have worked with the hospitals, for example, on tabletop exercises. And then, of course, the CDC is providing guidance on a national level that helps inform everything so that we're not reinventing the wheel 3,000 different ways in 3,000 different communities in the U.S. Training, we have staff that are trained that know how to do contact investigations, but specific training, should we ever need to do it, and making sure that we are ready ahead of time for a case that might show up in Nashville is an important thing. We've been in communication with hospitals, with fire department, EMS, and with others. I'm glad to see that there are some metro agencies here. I think there's probably some more conversations that we need to have to make sure that questions are answered about what might come up in different metro agencies with concern about Ebola. And should it be a concern? And if it is a concern, what should we do about it? And then public communication, I think, is really important because there's a whole layer of worry out there, and people really want, I think, for me and my family, I want to have the facts. I think everybody, it's natural that people want to be protected and people want to have the facts. So I'm getting ready to close up, and so you can start thinking of what some of your questions might be. There are no cases to date in Tennessee, but we would not be terribly surprised if another case did come or show up here in one of our hospitals. Ebola is not spread as easily as flu. It's not spread as easily as measles. It's not spread as easily as a whole lot of other viruses. And we talked about direct contact with body fluids. There are very few people in the U.S. at risk. We don't have widespread transmission, widespread virus going from person to person in the U.S. And so really what's important in assessing whether a risk is a travel history, symptoms and a travel history. And we do have confidence that we'll be able to contain Ebola virus disease in this country by identifying cases, isolating them, and then identifying and monitoring the contacts. I said there's this whole extra layer. It's like, depends on what TV channel you watch, you could get yourself very worried about Ebola virus. And it is something that's new. It's human nature to be worried and want to make sure that your family's protected. And it's what brings us to work is to want you to feel like you're going to be safe, or want you to actually be safe. So the first thing is know the facts. That's partly what we've been through this afternoon. Second, remember that the enemy is a virus. We have other enemies that are viruses, but we don't have enemies. Nothing about this is, the virus is not a person, a continent. It's not a group of people or an organization or a politician. It's important for us to focus on what works, and it's also important for us to stay informed. And you don't have to write all of this down, but certainly if you Googled cdc.gov, I'm sure it would be easy to find CDC's information on Ebola virus. Also, State Health Department, Tennessee Department of Public Health on Ebola. You can come to our website too, but one of the things we're not doing is we're not reinventing information that the CDC already has out there. Certainly if there's anything that happens in Nashville that is really specific to Ebola, we'll communicate it as publicly, as soon, as clearly, and as honestly as we can. I'm glad to say that right now in Nashville we don't have cases. I'm also confident that if we did have a case, that we would, between the medical community and the public health community, know what to do and do the best that we can, and also that we would be forthcoming with information and communicate about it. So with that, I'm going to open it up for questions. Thank you again for coming. Thanks for your interest. Thanks for your interest in protecting Nashville and in protecting yourselves and your families. Are there any questions? We actually have some folks with microphones. Okay. We need somebody to ask a question.
What is the standard treatment for, since there is no medication? What is the standard treatment for Ebola?
Right. Standard treatment is really what we would call supportive medical care. So if people are losing fluid, you want to replace fluid with IVs. You want to kind of monitor, and if their electrolytes or the salts in their blood are out of kilter, you want to correct those. So there's the kind of care that is ordinarily given every day to any patient in a hospital or in an intensive care unit, as the case may be. It's that supportive care to try and keep everything, keep the vital signs, keep everything where it needs to be, while the body fights off the virus with its own immune response. Yes. Hi.
Hi, how are you? My question is, I see we have this meeting here for individuals who could come, but I'm a Liberian. I'm an active traveling Liberian. The last time I was in Liberia was in April for a mission trip. And just the other day, I had a coworker come to me and say, so when did you come back from Liberia, and how do we know you're not a carrier? So how do we plan to reach the masses so that I won't be segregated in a sense, because you do have a humongous Liberian community here? And then my second question, when you said track cases, I have an aunt that's in Liberia now who's planning to come back in 3 weeks. So when we get her, do I take her somewhere? Like what is the protocol? What are we to do,
Those are good questions. This meeting right now is, I believe, being broadcasted. At least it's also being recorded. So people who are losing sleep over Ebola will be able to find this information online. And so I think that's an important thing. And it will take not just this, but a whole variety of us going back to our organizations to say, if they didn't have contact and it's been more than 3 weeks, there is nothing to worry about. And so it's not really about your nationality or about some travel you had a long time ago. It's really about contact with somebody who's sick. And also for people traveling here from Liberia, there is some screening that occurs in terms of asking those specific questions about contact, both on departure from the country, but also on ports of entry in the U.S. And so there is some screening that occurs with there are different ideas about that out there. But I think as far as I know, there's not a recommendation that a person who arrives from Liberia register. But it's important, if somebody could possibly have come in contact with somebody sick, that they self-monitor for 21 days, and that they go ahead and seek care right away and say, I was in Liberia less than 3 weeks ago. This fever, I'm worried about this fever. Can you please check me out? So those kinds of things people need to be aware of, and I'm sure that that's happening as the CDC's Division of Global Migration Quarantine checks people as they come from overseas. Yes.
Haley Mason, Channel 4. I know you didn't go into detail about personal protective equipment, but with the CDC's recommendations for PPE, can you speak specifically about how equipped local hospitals are with the PPE that the CDC has recommended, and if you all plan to go above and beyond that after what happened in Dallas with them not being properly dressed?
That's a good question. I can't stand here before you as a representative of all of Nashville's hospitals, but I will say we're in contact with the hospitals. The hospitals are well aware of the CDC recommendations. The state health department has one of the nation's experts on protecting healthcare workers, and I will guarantee you that they are paying attention. We checked in with them after the very first chapter in Dallas, and every hospital was having their tabletop exercises, making sure that the travel history was asked. So speaking specifically to what types of equipment hospitals are implementing and their procedures, I don't have specific answers for you, but I do know that this is high on the list for all of our hospitals, top to bottom. Yes.
Blake Farmer with Nashville Public Radio. Are there certain hospitals that have been selected as if an Ebola case was found in Nashville that they would automatically go to Vanderbilt or be transferred somewhere else?
I'm not aware that that's happened here in our community. I know that there are some designated hospitals that are biocontainment hospitals. I mean, I know what I read on the news, that one of the patients.
So there's not been
was
anything
transferred.
further than
In
that?
terms of a specific hospital in Tennessee, I'm not aware of anything.
Or some sort of plan that if somebody walked into an emergency room and might have Ebola, that they would head to a certain location?
Right now, I think every hospital wants to be prepared because the initial symptoms of Ebola are non-specific. Somebody walks in with a flu-like illness or vomiting and they've had a travel history. I think every hospital wants to be able to take care of that first encounter and protect their staff for that first encounter. There are discussions, I think probably at the state and national level about the possibility of using hospitals in a specialized way. I can't answer those right now.
I was just wondering if there's any plans to get all of the hospitals in one room so that we can discuss what we're finding with our exercises as far as where our holes are, where their holes are. This is what I created to fix mine, so that we can put our stuff together so that we're all not creating the same things when we can share them.
That's a good thought. Part of what we wanted to do with this meeting is listen to people, and we have representatives from both local and the state health department here. We'll take that up, and we'll see if there's an opportunity for that.
Danielle Lovell, the infection control nurse for Davidson County Sheriff's Department. We have all different types of people that come into booking. If they present with flu-like symptoms, what is the time span from flu-like symptoms to severe symptoms? Or do we have a ratio on that?
It's a matter of days, but I would say that if you're, anybody presenting to healthcare with flu-like symptoms, we're recommending that the travel history be checked.
Okay.
Now, obviously, there can be a grain of salt with some patients and the history that they offer, but you should be able to, that is a really important piece, because out of 1,000 people with flu-like symptoms, those people could be potentially contagious even before they get late symptoms, right? But only one of them or less than one of them is going to actually have Ebola. So I think that there's a basic approach to somebody who could be contagious. But without the travel history, I think the sort of level of anxiety of Ebola should go way, way down.
Dr. Paul, Jamie Tucker, I'm with Channel 2. There, as you mentioned in the slide presentation, there's very little chance that most of us would come in contact with a person's blood or other bodily fluids, except for sweat. For people who go to the gym or around other people, as we're sweating, as we shake hands with clammy hands, is that a risk? And talk a little bit more about that in some detail about the transmission of this through sweat.
I think when we list all those as potential sources of virus, we're talking about somebody who studied that by trying to find the virus in sweat and trying to find the virus in different body fluids. In terms of the epidemics and outbreaks, it is the more obvious things of stool, vomit, and blood that are overwhelmingly more likely to be a source of transmission. And I don't know if there's any particular case where it was transmitted for sure by sweat. It doesn't travel through intact skin. That's one thing. If you're talking about going to the gym or what have you, it doesn't travel through intact skin. I'd say, often probably a wise thing for people who have cuts or abrasions on their skin to sort of find a different way to greet people. But the other thing is, only sick people can spread the virus. And if you're sick, from what I understand about this illness, very few people are going to be sick with this illness and heading off to the gym. So I think that while it can be a concern, it shouldn't be a broad concern in terms of, I might catch it in that way.
What about the companies that have plants over in West Africa? Bridgestone, for example, headquartered here, has a big tire plant in Liberia with people traveling back and forth. What are the conversations to make sure that they are not coming back, or if they are being held there? What's going on with Metro and the people at Bridgestone?
Mm-hmm. I can't speak for Bridgestone, and I think that anybody who's traveling back and forth, the basic precautions as somebody comes back from a visit over there is going to be similar. I've read, I've heard about Ebola in the Firestone operation in Africa, but I've heard it from the press, and that there was what they did is they did what I just described over there. They did have some cases, but they've been able to be very successful in controlling the outbreak within the operation and where their employees are.
Doctor, I have one final question. Hector here with News 2, and my question is simple. You spoke about multiple strains of Ebola. Is any one particular strain more dangerous than any other strain, or should we be more concerned about any one particular strain?
I think that's probably not something to worry about very much right now. I think that what we've got is one strain that's really being transmitted widely in West Africa, and that's the strain that's of public health concern for us right now. Certainly, if somebody's going to a remote area in the Congo, or has some very particular travel plan or concern, then you might want to talk about different strains. But for our purposes, we're not getting into finer differences between the different strains. So thank you all for coming. If any of you in the audience want to stick around, I'm available, and we have some other folks that are public health experts available. Appreciate your interest, appreciate your concern, appreciate your telling people that they can find information in these places. And this particular session will be available on our website, on the Channel 3 website, as we go forward. Once again, thanks. Have a good day. Take care.
First response.